Hi, my name is DBurnsworth. I am a family nurse practitioner student at University of Florida. My presentation focuses on Kolcaba's theory of comfort. Before beginning my presentation, I'd like you to take a moment to think about how you define comfort. What does comfort mean to you? Is comfort an important concept in nursing care? What effect does increasing comfort have on our patients? We often provide comfort care to our patients as nurses, but have you ever thought of how that would affect long-term outcomes for your patients, or how that may affect the institution where you work? After further discussion of the theory of comfort, I am hoping you have a better understanding of this concept and how it impacts healthcare situations and outcomes. Kolcaba is the nursing theorist that developed the theory of comfort in the 1990s. She has a PhD in nursing from Case Western Reserve University and is currently an associate professor in the College of Nursing at the University of Akron. She continues to research and develop the comfort theory. This is a timeline of events throughout the development process of the theory of comfort. From 1991 to 2001, the theory of comfort was developed and expanded. In 1991, Kolcaba published 2 articles, one being an analysis of the concept of comfort, in which Kolcaba explored the many definitions of comfort to clarify its use in nursing practice, theory, and research. In a taxonomic structure for the concept of nursing, she organized the 3 senses of comfort and the 4 contexts into a taxonomic structure that can be used as a guide for assessment, measurement, and evaluation of patient comfort. In 1994, a theory of holistic comfort in nursing was published. This article includes 6 defining factors that examine why comfort is a significant middle-range theory. In 1995, the Art of Comfort Care was published. This provided a template for practicing the nursing art of comfort care. It included propositions for comfort care derived from the theory of comfort and included benefits for integrating comfort care into practice as well as nursing education. In 2001, the Evolution of Mid-Range Theory of Comfort for Outcomes Research was published. This examined the developmental stages of the theory of comfort and how the current theory has been adapted for the rapidly changing healthcare environment. In 2003, Kolcaba published a book titled Comfort Theory and Practice, A Vision for Holistic Healthcare and Research. An overview of the theory of comfort. To me, the theory of comfort is a holistic approach to achieve comfort in nursing care by assessing the comfort needs of patients and designing interventions to meet those needs. As comfort increases, as does the overall well-being of the patient. As satisfaction increases, the patient is more likely to engage in behaviors that lead to better health. As comfort is achieved, the patient begins to heal faster. Kolcaba defines comfort as the satisfaction of the basic human needs for relief, ease, and transcendence arising from healthcare situations that are stressful. Defining relief as the state of having had a specific need met, ease as the state of calm and contentment, and transcendence as the state in which one rises above problems or pain. She explains that a client's needs arise from a stimulus situation that can cause negative tension. Comfort is viewed as an outcome of care that can promote or facilitate health-seeking behaviors. These 3 types of comfort, relief, ease, and transcendence, occur in 4 contexts of experience. Physical, which pertains to bodily sensations or functioning. Psychospiritual, which pertains to an internal awareness of self. Sociocultural, which pertains to interpersonal, family, and societal relationships. And environmental, which pertains to one's relationship with external surroundings and conditions. In this model, nursing is described as the process of assessing a patient's comfort needs, developing a plan, and evaluating patient comfort after implementation of the plan. The theory of comfort is a middle-range nursing theory designed for nursing practice, research, and education. This theory has undergone changes and has been tested, over time for practice applicability. In the 1980s, Catherine Kolcaba was a graduate student and head nurse on an Alzheimer's unit. As a graduate school assignment, she was asked to diagram her practice. She used current terms that commonly describe dementia care and drew relationships between them. However, she found these terms and relationships did not completely describe her practice. This sparked an inquiry as to what was missing. She introduced the concept of comfort into the diagram. From here, she developed a framework for dementia. She presented this framework at a gerontological conference, and the audience suggested the framework was applicable to many nursing settings. This led her to begin an analysis of the concept of comfort. The concept analysis of comfort began with an extensive literature review. Kolcaba looked at comfort in many different disciplines, including medicine, psychology, psychiatry, nursing theory, and past and present textbooks. Comfort was often discussed but not clearly defined in the literature. Uses of the word varied and were not clear. This led to the three technical senses of comfort currently used: relief, ease, and transcendence. Further understanding explained comfort needs occurring in both a physical and a mental context, and comfort was described as a holistic outcome. The work of Henry Murray and his colleagues on personality theories in 1938 provides the framework for Kolcaba's theory of comfort. In summary, the model of human press states that needs arise from a stimulus situation. The situation includes what Murray defined as alpha and beta press. In terms of nursing, the stimulus situation can be any healthcare situation. Alpha press includes the obstructing, facilitating, and interacting forces. The obstructing forces are the negative stimuli resulting from the healthcare situation. For example, unwanted medication side effects, pain, fear, or anxiety. The facilitating factors are the nursing interventions designed to meet the patient needs. The interacting forces are the intervening variables. Beta press is described as the person's perception of how well the nursing interventions or the facilitating forces meet the needs that have arisen from the healthcare situation or the obstructing force. The model of human press suggests that if needs are met by appropriate interventions, the outcome is perceived as positive. Perceptions of comfort imply negative tensions have been reduced. A relationship exists between health-seeking behaviors and comfort. Health-seeking behaviors can enhance comfort. Kolcaba added nursing concepts to Murray's abstract framework. It is clear to see how Murray's model of human press laid the foundation for the comfort theory. Murray's theory was based on meeting human needs in patients who experience stimuli in stressful situations while considering interacting forces that affect patient perception. Some ideas incorporated into Kolcaba's theory of comfort include those that were borrowed. Health-seeking behavior was a concept created by Rosella Schlofeld. Health-seeking behaviors are patient actions that are predictors or indicators of improved health. She described health-seeking behaviors as internal, external, or a peaceful death. Ideas about relief, ease, and transcendence were also borrowed. The theory of comfort has expanded and evolved over time. Comfort is described as the immediate desired outcome of nursing care and strengthens patient engagement in health-seeking behaviors. As the theory of comfort expanded, it came to include a relationship between health-seeking behaviors and institutional integrity. The definition of institutional integrity was expanded to include healthcare organizations at local, regional, state, and national levels. The theoretical framework for Kolcaba's theory of comfort. The theory states that in a stressful healthcare situation, unmet needs of comfort Nursing interventions are successful if enhanced comfort is achieved by patients compared with the previous baseline. The immediate patient outcome of enhanced comfort is theoretically strengthening. Holism is at the center of the theory of comfort. There are 7 main defined concepts in Kolcaba's theory of comfort. Comfort is the satisfaction of basic human need for relief, ease, and transcendence. This is an immediate, desirable outcome of nursing. Comfort care is the intentional comforting actions of nurses. Comfort measures are the interventions. Comfort needs are the needs identified by nurses. Health-seeking behaviors are predictors or indicators of improved health. Institutional integrity are the values, financial stability, and wholeness of healthcare organizations at all levels. Intervening variables are those factors which are not likely to change over time and which providers have little control over. There are 8 defined propositions that connect the major defined concepts and form the conceptual relationships in Kolcaba's theory of comfort. Comfort needs of the patient and or the family are identified by nurses. Interventions are designed to meet those comfort needs while considering intervening variables. Comfort care and measures are implemented. Patients and nurses agree on desirable and attainable health-seeking behaviors. Increasing comfort can promote health-seeking behaviors. As enhanced comfort is achieved, the likelihood to engage in health-seeking behaviors enhances, and these behaviors further enhance comfort. As patients and families engage in health-seeking behaviors, this improves their satisfaction with care. This can then lead to better healthcare outcomes and satisfaction within an entire institution. Understanding this theory and its concepts promotes holistic nursing care. Evidence-based practice or policy improvement may be guided by these propositions. As stated by Kolcaba, there are 4 broad assumptions in the theory of comfort. Human beings have holistic responses to complex stimuli. Comfort is a desirable, holistic outcome that is relevant to the discipline of nursing. Human beings actively strive to meet or to have met their basic comfort needs. And institutional integrity has a normative and descriptive component that is based on a patient-oriented value system. Now, with a better understanding of the theory, we can analyze and evaluate the theory of comfort. I will begin with internal criticism. This deals with the criteria concerning the internal dimensions of the theory and how the components fit together with each other. Adequacy is how completely the theory addresses the topics it claims to address. The theory of comfort completely addresses the concept of comfort by defining the concept, defining the related concepts, and then explaining the propositions and assumptions. Inadequacies of the theory were recognized, and it has been refined over time to close gaps. Kolcaba's theory considers intervening variables and their effect on comfort. The concept and definition of institutional integrity was added to the theory just recently to keep up with the current trends in healthcare and to also measure outcomes in nursing care. This theory demonstrates adequacy by addressing the topics it claims to address and evolving over time to better address the concepts and propositions to further enhance nursing practice. Clarity addresses if the theory clearly states the main components to be considered and is clearly understood by the reader. The 7 major components of the theory of comfort are clearly defined and easily understood. Comfort, comfort care, comfort measures, comfort needs, intervening variables, health-seeking behaviors, and institutional integrity are all defined in addition to the concept of comfort, relief, ease, and transcendence. 8 defined propositions are included, and assumptions are logically described. The propositions connect the major concepts for the reader. In analyzing and evaluating a theory, consistency addresses if the theory theory of comfort has expanded the definition of comfort from its early definition, but has remained an immediate, desired outcome of nursing care, according to Kolcaba as defined in the theory of comfort. The theory has maintained the definitions of the key concepts throughout years of explanation and implementation of this theory, to include comfort care, comfort needs, comfort measures, health-seeking behaviors, and intervening variables. Comfort and the major concepts associated have remained consistent over time, with the addition of institutional integrity as a major concept, as Murray's 20th century framework could not account for the current emphasis on institutional outcomes. The purpose of this theory has remained consistent, but some changes to improve nursing outcomes have been included. Logical development addresses whether the theory follows a line of thought of previous work that has been shown to be true, or if it enters new territory. Although the foundation of Kolcaba's theory of comfort stems from work by Henry Murray, the concept of comfort was discussed in previous work, but not consistently defined until Kolcaba in 1991. Concept analysis and development of this theory was inspired by Kolcaba's own personal clinical practice. The theory of comfort itself is logical, systematic, and easy to follow. The taxonomic structure of comfort Kolcaba developed is easily operationalized. The level of theory development addresses whether the theory is in early stages of development or if it has been developed over several decades. The theory of comfort is a relatively new theory and was first introduced in 1991 and published in 1994. However, the theory of comfort is commonly used and can be applied to many different nursing situations. It has been used in research studies related to end-of-life care, pediatrics, peri-anesthesia care, breast cancer, and hospice, just to name a few. The outcomes of this theory are measurable, holistic, and nurse-sensitive. We will look more specifically at several of the independent research studies conducted applying the theory of comfort later in the presentation. Now we will look at the analysis and evaluation of the theory of comfort in terms of external criticism. External criticism considers the fit between the theory and criteria external to the theory, for example, the social environment. External criticism depends on individual preference and the perceptions of the evaluator. Complexity addresses how many concepts are involved as key components of the theory. It assesses how complicated the description of the theory is and determines whether it can be understood without lengthy explanations. As previously described, the theory of comfort includes 7 major, well-defined concepts in 4 different contexts. The 8 propositions connect the concepts and provide a simple explanation of how the concepts are related. Kolcaba defines comfort in a positive concept. The taxonomic structure allows for identification of comfort needs, generation of interventions to meet those needs, and simple measurement of the effectiveness of those interventions. Discrimination determines whether the hypothesis resulting from the theory led to research results that would not have been possible with the use of other nursing theories. It addresses the uniqueness of the theory to the area of nursing which it addresses and assesses whether it has precise and clear boundaries of the subject matter. Kolcaba describes comfort care as being provided by nurses. Nurses have frequent direct contact with patients and are essential in providing comfort. Nurses are the ones assessing, monitoring, providing interventions most commonly to patients. The outcomes of this theory are needs-based and nurse-sensitive. They are unique and relevant to nursing. Reality convergence assesses how well the theory builds upon the premises from which it is derived and relates that to reality. Catherine Kolcaba achieves reality convergence in that she based the theory of comfort on the early work of Henry Murray, but as she stated personally, she hung nursing concepts on his abstract framework in a unique way. I would not go as far as to saying she's a deconstructionist, but I do believe it is safe to say that Dr. Kolcaba is a pioneer in nursing theory related to comfort. As nurses, we are expected to provide comfort to patients. As we work to enhance patient comfort, our patients are more likely to engage in health-seeking behaviors, leading to better health outcomes. Kolcaba's theory of comfort is absolutely pragmatic, can be, has been, and is applied in a variety of real-life nursing settings. As a simple example, we could look at postoperative pain. You have a post-op patient that is restless and grimacing. You identify the apparent need for pain relief and formulate a plan to enhance comfort. You implement comfort care and measures by repositioning the patient, applying an ice pack to the surgical site, and administering IV analgesia. The goal is for the patient to report increased comfort, appear more comfortable, and recognize the early signs of discomfort. You provide these interventions in a timely manner. The patient thanks you for your care and later writes a letter to the chief nursing officer commending you for their increased satisfaction with care. This then impacts the institution where you work. That is just a simple example of how we could use the theory of comfort in our everyday care. As a published example, Kolcaba and DeMarco examined the application of comfort theory in pediatric nursing, not only assessing pain, but comfort measures. The scope of the theory is how broad or how narrow the range of phenomena is that the theory addresses. The theory of comfort is narrow in that it focuses on a very specific set of concepts related to comfort and is geared toward the comfort needs of patients and family. However, I believe this theory could become much more broad as it continues to be tested in different patient settings. Significance determines whether the result of research that is conducted because of hypotheses generated by the theory will have any impact on the way nurses carry out interventions in the real world. As nurses, we want what is best for our patients. Implementing interventions to enhance comfort increases patient and family engagement in health-seeking behaviors, which in turn further enhance comfort. This can lead to better health for our patients. The theory of comfort also relates practice to institutional outcomes, which may affect not only patient satisfaction, but also nursing satisfaction. This theory has great significance on the way that nurses carry out interventions in practice. Utility assesses if the theory is useful in practice by the nurses researching it. The theory of comfort has a limited number of concepts and propositions, low level of abstraction, and ease of application to actual practice. It can be used in different settings and can be simply measured using tools developed by Kolcaba, including the General Comfort Questionnaire, the Verbal Rating Scale Questionnaire, and the Comfort Behaviors Checklist. An example to this usefulness in practice is peri-anesthesia nurses have developed clinical practice guidelines based from the theory of comfort. Kolcaba developed tools to measure the concepts and propositions described in the comfort theory. The GCQ, or the General Comfort Questionnaire, is a 48-item Likert-type scale. This has been modified for use in different populations, and a shortened version including 28 items is also in use. Other tools developed by Dr. Kolcaba to measure the comfort theory include the Verbal Rating Scale Questionnaire, Comfort Behaviors Checklist, and other more specific questionnaires, such as the Radiation Therapy Comfort Questionnaire, the Hospice Comfort Questionnaire, and the Urinary Incontinence and Frequency Comfort Questionnaire. These instruments have been used in studies applying the comfort theory to different areas of nursing. Throughout my exploration of Kolcaba's theory of comfort, I was impressed as to how much information and research is published based on this theory. In the following slides, we will look at 3 published research articles based on Kolcaba's theory of comfort. The first, titled Measuring Comfort in Caregivers and Patients During Late End-of-Life Care by Beverly Novak, Catherine Kolcaba, Richard Steiger, and Theresa Dowd. The purpose of this study was to evaluate end-of-life comfort instruments for patients and closely involved caregivers using Kolcaba's theory of comfort as a theoretical framework. The basis for this study was the ANA's position on end-of-life care, which states that comfort is a goal of nursing in this population. The methods included end-of-life comfort questionnaires collected from 2 hospice agencies. The findings resulted and revealed in strong reliability and beginning validity for the use of these end-of-life questionnaires based on Kolcaba's theory of comfort. The next published article examined is titled Comfort Theory and Its Application to Pediatric Nursing by Catherine Kolcaba and Marguerite DeMarco. The purpose of this position statement was to examine the framework of the comfort theory for pediatric practice and how to apply this theory to strengthen and satisfy the needs of both pediatric patients and families. The position statement suggested the use of the comfort behavior checklist and other ways to apply the theory to pediatric nursing. Implications for research suggest that interventions that enhance holistic comfort care in children are desirable, but also unexplored outcomes of care. This opens the door for the application of the comfort theory in pediatric nursing. The last study examined, titled Family Presence During Cardiopulmonary Resuscitation, Using Evidence-Based Knowledge to Guide the Advanced Practice Nurse in Developing Formal Policy and Practice Guidelines by Christopher Dolan, Lisa Quinn, Leslie Bryant, Ian Lyons, and Ruth Kolcaba. The purpose was to provide advanced practice nurses with the best available evidence for implementation of policies and procedures to allow families presence during cardiopulmonary resuscitation in the acute care environment. This study used Kolcaba's theory of comfort in application to not the comfort of patients and families, but more so to the comfort of nurses. This is a study that broadens the scope of the comfort theory. Methods involved a literature review, and findings suggested that policies and procedures be put into place for resuscitative events. The researchers state that the comfort theory directly correlates with the initiatives of the American Association of Critical Care Nurses and provides direction for improvement. How can we apply Kolcaba's theory of comfort into practice? Just looking at the 3 articles discussed previously, you can see the diverse application of the comfort theory. In the first article, the theory was used as a theoretical framework for implementing end-of-life comfort questionnaires. The second article discussed how the theory can be applied to new areas of practice in which it is not being used. The last article broadens the aspect and examines nurse comfort and how the theory can be used to establish protocols, policies, and even clinical practice guidelines. With the inclusion of the concept of institutional integrity, I believe this opens the door for new evidence-based practice research and outcomes examining the relationships between health-seeking behaviors and institutional integrity. Further research may explore nursing comfort in addition to patient and family comfort and how enhancing nurse comfort affects patient comfort. As an end note, this is a quote from Dr. Kolcaba herself. When presenting comfort care to students a few years ago, one earnest young man who had some prior experience working in nursing homes raised his hand and asked, "Is this a new concept? I have never seen it being practiced." I think his question is a wake-up call to us in nursing practice and education to get back to the basics. I hope you have a better understanding of comfort, how it pertains to nursing, and how we can apply the theory of comfort to improve the overall well-being of our patients while providing holistic care. Thank you for listening.